Hello, today I'm going to be lecturing on section GG, which is the modification or update from the FIM, or a functional independence measure. And so this comes directly from the Centers for Medicare and Medicaid Services, or CMS. For the learning objectives, I want you guys to understand and identify the relevance of section GG across all post-acute care settings. We'll talk about each of these settings very briefly, and I'll show you a slide where section GG has been implemented for each of these settings. I'd like you guys to understand why section GG was developed. Identify the components that make up section GG self-care items, and apply section GG coding principles to identify appropriate levels of performance. So this all began in 2014 with the Impact Act of 2014. And so this was a bipartisan bill signed into law October 6th. And essentially it was saying that all of these facilities needed to submit standardized data of their clients or of their residents or patients. And so you can see that section GG has eventually been implemented in inpatient rehab facilities, skilled nursing facilities, home health agencies, and long-term care hospitals. So essentially this act was telling these facilities that they had to have some method of tracking what level of function their patients were in when they became admitted or when they were discharged. So here you see the different types of assessment measures that were used per site for that standardization. So inpatient rehabilitation facilities have used what was called a patient assessment instrument. And so these types of assessments, you guys, are all compiled with various disciplines in mind. So you might have a nurse that does some type of assessment, and she records her data in this facility assessment. Okay, the PT may be recording some of the information that gets submitted with this patient assessment instrument. The OT may be contributing to the patient assessment instrument. So it's a way that all disciplines are calculating a level of function for their patient or for their resident, again at the time of admission, and possibly again at the time of discharge, which is why this is all considered an outcome measure. In skilled nursing facilities, we've often heard this called MDS, and so again, it's just the way nursing homes were collecting data and reporting their data. Home health agencies had their outcome and assessment information set, or their big OASIS, again, which nursing, PT, OT could all contribute to that data. Long-term care hospitals look at the continuity assessment record and evaluation, or the CARE, if you will, or perhaps some other types of data sets. And so the issue began, or the issue became, that certain aspects with the inpatient rehab way of assessing eating was different than perhaps what was done with nursing homes. And that was different than what was done in home health. And that was different from basically long-term care hospitals. And so again, this is coming from Medicare, right? And so if you have somebody in an inpatient rehab setting and they do, or they assess eating upon admission and say they are maximum level of assistance for eating, right? And then they get discharged to a home health agency, and at the time of discharge, that inpatient rehab facility says that they are min assist, or minimum level of assistance, and then they're discharged to a home health agency, and then the person who assesses eating documents them as max assist. And so it's all being covered by Medicare, right? And so Medicare is going back and saying, okay, inpatient rehab, what has happened from your time of discharge, saying this client was at min assist with eating. However, your home health agency is saying they're max assist. Okay, that's not a reliable way of measuring eating. So eating is measured on all of these areas, and many of the self-care skills and functional abilities and all of those things are measured in each 4 of these data sets, but there was not a standardized way of measuring each of these things. And so you were having discrepancies from one facility to the other with how they were measuring certain items. And so again, that kind of impacts the reliability, right, of the data that's being gathered. And it's making Medicare scratch their heads going, well, this person was discharged from inpatient rehab because they didn't need assistance anymore, but now they're saying that they need assistance in this other facility. And so what has happened from the time of discharge to the admission, and something's not lining up here. And so that really caused Medicare and Medicaid to look at the Impact Act and try and come up with a better standardized way. So this kind of leads to the importance of data collection and standardized methods. And so standardized data collection should be used across all post-acute care settings. Again, post-acute care, you're looking at after that initial acute care when the patient is becoming more medically stable, right? Are they going to rehab? Are they going to home with home health? Are they going to maybe a skilled nursing facility? Or are they going to maybe a long-term care hospital? So again, depending on where they're being placed. This allows Medicare to look at if everybody throughout these settings are collecting data the same way, okay, then it helps us understand or it helps us compare data across all of these settings, right? So if we're assessing eating, or we're assessing toileting, or we're assessing upper body dressing at inpatient rehab, and the patient goes home and we're assessing that through home health, that we're doing it the same way, that we can compare, hey, they were min assist at the time of discharge with inpatient rehab, they should be min assist at the time of admission in home health. Okay, and so if we're all if we're all collecting the same data and we're able to share the use of that data, okay, this also helps us determine what would be the most appropriate outcome for our patient. Is the most appropriate outcome independence with upper extremity dressing or independence with toileting? And so if so, that would allow us, right, to work on inpatient rehab dressing, but at the time of discharge, maybe they're only at min assist. Well, then if we can share that data with people in home health and say this was our outcome was independence with upper extremity dressing, there can be that continuity of care or coordinated care efforts throughout the settings, right? And we can continue that patient's plan of care throughout the various settings they go through. Okay, and so again, that helps with quality care, the continuity of care. That helps with making sure that we're all assessing the same things in the same way. It helps us compare data across all of these continuums of care or different settings. If we're all assessing the same way and we're all doing it from a standardized method, then we should be able to have that free exchange of data and have it make sense per setting. This would help for improved discharge planning as well if we were all on the same page. So even within our facility, if we're working in inpatient rehab, right, and maybe the PT works on a transfer, works on a toilet transfer, and they say, oh, this patient is max assist. OT goes in there, works on a toilet transfer or assesses a toilet transfer and says, oh, they're minicyst. Well, which is it? They're both inpatient rehab, right? And so, again, this really helps with making sure we're all doing our assessment piece in a standardized manner, and we're contributing to the data of our overall assessments, right, with the OASIS or the MDS or the IRF plan, right? And so that allows us then to say, oh, well, they should be independent at the time of discharge here. Okay, so that helps with our discharge planning if we're all on the same page and we can all identify where they start with or what level they start with. Also, it helps make sure that we're coordinating care throughout our setting and across patient settings. And this also helps with our payment models, right? So if we're gathering data on somebody in an inpatient rehab facility, and most of the people in our setting, when at admission, they're requiring maximum assistance with their upper body dressing, their lower body dressing, their toileting. And then at discharge, after maybe 2 weeks of intensive inpatient rehab, we're seeing that they're at a level of independence or standby assistance. Then that gives Medicare a lot of informed research saying, hey, somebody with this diagnosis of a hip replacement, typically they're discharged from inpatient rehab after 2 weeks with a higher level of independence and function. So then they can further say, and they can further inform their reimbursement or payment process of these disciplines are needed for this particular diagnosis, and they may actually have great patient outcomes after just a couple weeks of rehab. So again, our Medicare and Medicaid are looking at how we can gather data from a standardized format so they can start to track and understand the levels of need patients may have based on their diagnoses. So the Impact Act requirements, again, looking at the clinical assessment domains and categories that each site, so inpatient rehab, skilled nursing facilities, home health care, long-term care hospitals, they all gather data relating to these areas. Okay, so functional status. So they're gathering information, these facilities are gathering information from PTs, OTs, nurses that look at measuring what a patient's functional status is at the time of admission. Okay, this is where Section GG fits in. Section GG, and we'll go through it again, is used as an outcome measure to assess a patient's current functional status with various types of activities and those kinds of things. And then again, scored at discharge, showing that their stay, they're making progress. And so, or they're ready to be discharged, or they're ready to move on to another continuum of care. So again, Section GG really looks at and is used with the functional status piece that is needed to be gathered with all of those sites, all of those post-acute care sites. Another area that perhaps nurses, OTs, maybe psychologists, other health professionals, maybe speech and language, right? Some of their data sets are being implemented and looked at for each of these settings to measure cognitive function and perhaps mental status. There's other areas of special services, treatments, and interventions. And so your sites or your locations may be gathering data, again, from nurses and other disciplines, and identifying what special services, treatments, and interventions are used for their patients. There's a site here also where all of these places should be gathering data on medical conditions and comorbidities, other impairments, or maybe other categories required by a particular secretary or somebody within that facility where they're looking at tracking some of that information. So again, your MDSs, your OASIS, your inpatient rehab measures, should be looking at all of these 6 areas, or each of these 6 areas, and reporting that in their MDS, in their OASIS, and in their other forms. Section GG goes hand in hand in helping us with functional status. Okay, so section GG is just a smaller component for each of these sites. So when we're looking at section GG and the post-acute care settings, so looking at long-term care hospitals, section GG was implemented beginning April 2016. And so they looked at using section GG for prior function, or so your everyday activities, prior device use, self-care, and mobility. You can see that inpatient rehab facilities followed suit of October of that year, as well as skilled nursing facilities. Okay, skilled nursing facilities also added more to section GG, or the implementation of section GG, in 2018. And then your home health agencies started using section GG in 2017 and have added more of section GG and have been utilizing it more since 2019. So again, looking at the common denominator here, self-care, we're going to focus on for this section of this course, just looking at how we would assess using section GG for self-care skills, as self-care skills are assessed quite frequently with OT, and we can contribute to these facilities' data gathering strategies for their organizations by looking at self-care. That doesn't mean we wouldn't contribute to mobility. That doesn't mean we wouldn't gather or maybe understand more about our clients' prior functioning and prior device use as well. That all comes into play with how we assess self-care as well. So again, that's where we're going to focus. And you can see, looking at being updated and fully implemented January 2019 in home health agencies, the importance of understanding this particular tool. So again, with section GG, it helps us focus on the client's functional abilities and where they're at currently, right? So if we understand where they're at currently, and we see a level of assistance that's needed, we can further identify perhaps more appropriate goals that us as the whole team of PTs, OTs, nurses, speech therapists can help that patient rehab or rehabilitate to get them at a more functional level of independence. Section GG does a really nice job of assessing the need of assistance for self-care skills and mobility, and I'll focus again more on self-care skills in a few seconds or a few minutes. And it really helps patients, residents with functional limitations because we can identify those people who need more levels of assistance. We can step in and provide more levels of intervention for them, which will help prevent further decline and complications due to due to limited mobility, right? So if we can identify the need sooner and their level of assist sooner, and we can provide more care earlier in the process, we probably could prevent further functional decline, right, from just general debility. We could prevent things like bed sores or pressure sores. We could prevent things from pain and contractures to all kinds of things. And just, we know research has said the earlier we get patients up and moving, the more functional their hospital stay will be. So when we're scoring section GG, or if we're tasked with scoring section GG, there's a way that we would be able to implement that, or a way that we would be recording that into the facility some way. And so a lot of these things are done electronically now, as you know. And so if we're tasked as OT to go in and provide some section GG scores, right, we would be entering in those scores, and then the computer system would score our particular patients or residents by taking what score we documented. This helps the facility track, again, how much time is being used, how much services are being used in rehab, if you will, and what that outcome is for our residents, or for our clients or patients. Okay, so it helps us determine that outcome measure, and if our client has made progress at the time of discharge. It also helps us determine a risk across settings. Okay, and so basically it's looking at maybe changes in skin integrity. Okay, so more people, if they're not up and moving around, and they're more sedentary, and they're having decreased appetite, so then their nutrition is lower, and they're not moving, so they have decreased circulation, and maybe they have other types of comorbidities like diabetes. Well, that's going to increase the risk for skin issues and skin integrity. And so different ways of that section GG can be scored will help flag those people who are at higher risk for some different risks that would affect their overall function or overall outcome measures. So section GG, again, when we're looking at scoring each of these areas, and again, it's not just OT doing this, it's we may contribute to a very small piece of this with our assessments, right? But this is a much grander scale that's more multidisciplinary. So we may be contributing to each of these scores in some way, shape, or form, and helping the facility document them. They would be looking at, we're assessing them using section GG on admission for everything, right? We want to figure out where their prior level of functioning was when they become admitted to the facility. We want to find out what their prior device use was at the admission to our facility. We want to find out what level of care they need for their self-care skills upon admission, and we want to find out what their level of care is for mobility, or their level of assistance needed for mobility at admission. At the time of discharge, we would be scoring them again, predominantly with their self-care and with their mobility. So this, again, this really helps track our outcomes, right? And we can use self-care and mobility as our outcome to see if our therapy services, or if their stay in the facility, actually increase their overall function with self-care and mobility. Okay, now each site, each facility, a skilled nursing facility, home health, inpatient rehab, long-term care, hospital, okay, each of them have different stipulations or different windows of time when that admission assessment would take place. Okay, and I'm not going to get into that. You guys will learn those as you go out on perhaps level 2 field work, and you experience those. But the takeaway point I want you to get from this is there is an admission score, right? And then for self-care and mobility, there's also a discharge score. So you're doing a pre-test and a post-test, and looking at these scores to determine your the quality of services that you've given. So this is assessing self-care and assessing mobility. And so each of these codes, section GG, section GG 0130 is self-care, GG 0170 is mobility. And so for both of these areas, they're saying when possible, the Center for Medicare says use multidisciplinary approach. So have nurses contribute to these scores by what direct observations they have with their patients. Have PTs go in and add or contribute to the scores of section GG based on what they're observing. Have OTs go in there with their direct observation, and again, I feel like we're such experts with self-care skills. And so again, you're going to be seeing different disciplines contribute to the section GG scores. For some of the items, it also may be acceptable to get some patient self-care report or a patient report, maybe some other clinicians, their report based on what they're directly observing, or perhaps some family members too. So we can keep that in mind when going through and scoring different aspects of section GG. So when we're administering section GG, we want to make sure that our patients or residents are performing their activities as independently as possible and making sure they're safe. So we really want to make sure that we're identifying if help or assistance is required and to determine how much assistance is required. And so this becomes a challenge, or this becomes fairly subjective, because different disciplines may have different backgrounds with helping patients. So I think of a lot of times our nursing staff would go in, right, and look at maybe a transfer with a patient or helping them to and from the toilet. Well, nurses tend to take care of their patients. They tend to do a lot of the work for their patients, right? And so a lot of times our nurses were writing that the patient was dependent with toileting. And so then OT would go in there and say, okay, let's get you to and from the toilet. I'm going to have you do as much as you can for yourself, right? And we would just stand by and observe and see if we needed to provide any assistance, and if so, where we would provide that assistance with. And so then as OT and assessing toileting, I may come out from that session and say, oh, my patient only required standby assist. So within the facility, there's all this confusion saying, well, the nurses are saying they're dependent with toileting. Well, yeah, because they didn't give them the opportunity to toilet themselves, right? And then OT is saying, no, they were, required a lot less assistance than that. And so again, the facility is charged with documenting what level of assistance there is. And which one do they use? Do they use the one that says dependent, or do they use the one that says, I can't even remember what I said, standby assist or min assist or independent, right? Which one did they use? And so having that discrepancy within the facility can be can be a red flag to Medicare. And so that's another reason why they have section GG, is they're saying during this assessment period, during this assessment time, no matter what discipline is assessing, we need to encourage our patient to be as independent as possible and making sure that we're going in with that mindset. Now, an update that's been done from the functional independence measure to section GG is they're saying with section GG that a patient can use an assistive device in order to be independent with a self-care skill. Okay, so if we're assessing lower extremity or lower body dressing, right, which just includes underwear and pants, if our client can do that with a reacher, and they can do it independently with a reacher, then we would score them as independent. Okay, so we wouldn't deduct any points from them for using that assistive device as long as they could use that assistive device independently. So here's the 6-point scale that we would be using with the use of section GG, and I'll be going through each one of these. It might be helpful for you to go along or follow along with the section GG decision tree also, which helps further you further identify different areas within, or different ways that we would score. So again, I think in some facilities that have not used section GG, their therapists have always used different levels of assistance to measure overall function. And so again, section GG is meant to help practitioners across the facility and across facilities to really identify what does independent mean, what does setup or cleanup assistance mean, what is supervision, what is moderate assistance, what is maximal assistance. And section GG does a much better job of standardizing that format for us instead of it just being subjective. So there comes a time, or there comes times when we are going through the coding process or levels of assistance, and there may be items that aren't attempted. And so there's different reasons why they wouldn't be attempted, and I'll kind of show you, or you can kind of see on the slide why they may not be attempted. And if so, then there's separate codes that we would use. And so instead of coding 6 as independent, right, if a patient or just refused to complete the activity, right, we just would code it as a 0-7 that they refused. If it wasn't attempted because it maybe is not applicable to test, perhaps the patient did not perform the activity prior to their exacerbation or injury, so they've never done their lower body dressing, they've always had somebody do that for them, then that's something that we could just mark as not applicable. Code 10 might be used if you don't attempt something because of environmental limitations. Okay, so maybe the patient has a tub at home, and that's the only way they perform their bathing is with the use of a tub. And in your facility, maybe you just have a walk-in shower or a roll-in shower. So if you don't have that equipment that's needed, or perhaps there's weather constraints, something along those lines, you could just code it as a 10, not attempted because something in the environment was limiting you to assess it. I think this code 88 is quite important. Perhaps there's something that's not attempted because of their medical condition. There may be a safety risk. So I think of eating as a particular area that's assessed, and perhaps somebody just had a stroke and they're at risk for dysphagia, and so perhaps we're not assessing this with section GG because it's not safe for them. They probably would aspirate, and so again, this would be something not attempted because of a safety concern. So this is part of the decision tree, and I tried to lump some of them together to try and cut back on slides because this just was an overwhelming piece. But this is your decision tree, helps you identify, so whatever you're assessing, saying it's eating. So you would go through each one and ask yourself these questions. Does the patient complete the activity by him or herself with no assistance, meaning no physical assistance, no verbal or nonverbal cueing, and doesn't require help for setup or cleanup? And so if you can say yes to that, you would score them as 6, independent. Okay, if you score, or if you answer no, they need physical assistance or some nonverbal cueing or help with setup or cleanup, then you would go to code 5. Does the patient need only setup or cleanup assistance from one helper? So this is maybe somebody bringing them their food, setting it on their nightstand, opening up their carton of milk, and then being able to let them finish up from there. So that would be assistance for setup, right? So if yes, that's all you do, then you would code them a 5, meaning setup or cleanup assistance. If you answer no to that, meaning they need more help, then you would go to section 4, supervision or touching assistance. Does the patient need only verbal, nonverbal cueing or touching, steadying, contact guard assist from one helper? And when I say contact guard assist, I'm meaning like I am on guard, ready to jump in and supervise or touch them or something. I am on guard, ready to provide assistance at any given moment. Okay, so if that's where I'm at, yes, that's what they needed, then they would have a score of 4. If not, I would move to code 3. So code 3 is partial or moderate assistance. So does the patient need physical assistance with a helper providing less than half of the effort? Okay, this is very important, less than half of the effort. Later on, when we go through each of the self-care items, we will add up how many tasks are in each component, and you will calculate how much physical assistance did I give them with the number of tasks that were administered. Okay, and so then if it's less than half of the effort, providing physical assistance, maybe you physically lifted them, or maybe you physically provided some support for them with the task, then you would code them a level 3. If they needed more than half of the effort, you would go to code 2, meaning substantial or maximal assistance. So does the patient need physical assistance with a helper providing more than half the effort? Okay, so again, this is where you would look at the item, right? You would calculate the number of steps for that item and determine how many of those items you provided physical assistance, where you were lifting or providing trunk support or providing some sort of physical assistance with them. And it would have to be more than half of that tasks. If yes, you would score it a 2. If no, you would calculate it as a dependent, meaning that the helper provides all of the effort, or the assistance of 2 people are needed in order to complete the activity. Okay, and so this is called your decision tree. It just, when you're looking at each task, you have to ask yourself each of these questions to determine what is the appropriate code and level of assistance your patient needs. So when we're looking at GG 130, again, it's the items that assess the level of independence with self-care activities. So patients and residents may have self-care limitations, and we're really looking at the admission or the start of care date. Okay, and so again, we're trying to assess that risk, or we're trying to assess that level of assistance. And typically, when people are newly admitted, they're going to require more assistance, right? So when we identify what level of assistance they are, we can identify what do they have to do at home. We can set that appropriate goal for them, and then we can get them moving. We can get them in that right direction to increase their independence. And so the longer a patient is, the more, how do I word this? The more assistance a patient needs for a longer period of time, they're going to increase their decline. They're going to increase their functional decline or decrease their overall function. And so we want to get them up and moving as much and as quickly as possible. So that's what this is saying. So as we're going through and as we're coding, okay, just a reminder, we want to allow the patient or resident to perform activities as independently as possible. Okay, so the way we code is based on the need for the assistance to perform the activity safely. Okay, so we want to make sure that they're being safe. And again, as a reminder, if a patient uses adaptive devices or assistive devices to be independent, we can include the use of that. Okay, so if they need a reacher to put on their pants and their underpants, and they can do so with the reacher independently, then we would still be able to code them as independent. So these are the different, so this is what it looks like. This is what section GG would look like. And so we're having that start of care performance. And so this is where somebody would be tasked with, and perhaps the facility, perhaps it's you, but they would be tasked with entering in the appropriate section GG codes at the start of care. Okay, then they might have, the facility might have a discharge goal. So maybe a group of people from the rehab facility would say, hey, I think Miss Smith, because of her diagnosis, I think we could get her here by the time of discharge. And so section GG, we're looking at eating, oral hygiene, toileting hygiene, showering and bathing self, upper body dressing, lower body dressing, and putting on and taking off footwear. So these are the things that compromise self-care in section GG. Each of these items gives you a definition that you will want to refer back to. Okay, that helps you figure out exactly how many tasks are in each item. How many tasks are in self-care skills. That's needed so you know whether or not they need more than half assistance or less than half assistance. So if we're looking at eating, okay, eating is defined as the ability to use sustainable or suitable utensils to bring food and or liquid to the mouth and swallow the food and or liquid once the meal is placed before the patient resident. Okay, so that tells me that once that meal is placed in front of them, I'm going to be assessing how they bring up the food from their plate to their mouth, how they're able to chew and swallow safely. Okay, and so I can count those steps of picking up with a spoon, right? Scooping, putting it in your mouth, okay, chewing, swallowing, picking up my cup, drinking, swallowing, and so I can count how many of those tasks are, and then I go back to my decision tree and say, okay, how many of those items did I give physical assistance with? Okay, how many times or how much verbal cueing did I give my patient for safety of making sure that they didn't choke or checking their mouth, those kinds of things. And so then I could calculate that to determine and go through my decision tree in determining the most appropriate code. The ability to use suitable items to clean teeth. So maybe this is toothpaste and toothbrush. Okay. Dentures. So if they have dentures, can they take them in or put them in? Can they take them out? Can they soak and rinse them with use of whatever equipment that they're used to using? Perhaps a toothbrush. Toileting hygiene. So are they able to maintain perineal hygiene? Are they able to adjust clothing before and after voiding or having a bowel movement? And then if they have an ostomy, you would include wiping the opening, but not necessarily managing the overall equipment. Showering and bathing self includes the ability to bathe self. It includes washing. Okay, so that's one step, washing, rinsing, and drying self. Okay, and it does not include getting in and out of the shower. Later on, I'll give you some further stipulations as far as what tasks are included with bathing as well. That's kind of, I don't know, it's kind of interesting. For some facilities, like skilled nursing facilities, right, there may not, if they're going to live in the skilled nursing facility and they're never going to be discharged, then chances are, you know, bathing might not be necessarily appropriate. And so for that type of facility, they do have an alternate shower and bathing self of just washing upper body. Okay, and so again, if you're in a skilled nursing facility, this might look a little different, or these tasks might look a little different based on that particular setting. Okay, and so again, I didn't want to overwhelm you with all of the what-if scenarios, because I think you'll learn that if you go into one of these settings. Upper body dressing includes the ability to dress and undress above the waist, and it also includes fasteners. Lower body dressing is the ability to dress and undress below the waist, including fasteners, but it does not include footwear, okay? Because that is the last and separate section, putting on and taking off footwear. So being able to put on and take off your socks and shoes and your ability to fasten. Okay, and so those are all of the self-care items. Again, I think it ties in very, very nicely to what we would be assessing as OTs in these particular settings. So I'll go through each one, provide a little bit more clarity or a little bit more depth. Again, looking at eating is the ability to use utensils and or use utensils to bring food and or liquid to the mouth and to swallow. Okay, so just some points of interest. I thought if somebody is being tube fed, we don't consider that as part of eating. So if the patient or resident's unable to eat or drink by mouth because they're being tube fed, okay, we just simply would code it as not attempted due to a medical condition. So usually if they're being tube fed, it's because they're not safe with the overall swallowing. Okay, and so that is that's important, right? So if they're unable to eat or drink by mouth and they're relying just on tube feedings alone, then we probably wouldn't want to attempt this one. If the patient or resident does not eat or drink by mouth at the time we assess them, and did not eat or drink by mouth prior to their current illness, we would just put not applicable. And so these might be some of your patients who have had a long-standing history of a stroke, and maybe they've been tube fed for a long period of time, and it's not something that's new. And so we wouldn't need to include that. It just would be not applicable. Oops. Oral hygiene. Or I guess more tips. I was trying to go back in my slide and I didn't get a chance to, but patient resident may be eating by mouth even though he or she receives liquid or nutrition via tube feeding. And so if a resident relies partially on tube feedings based on the amount of assistance, okay, so you can follow through with the section GG with eating and assess that further if they get partial feedings. So now I'm on this slide. Now we're looking at oral hygiene, the ability to use suitable items to clean teeth, dentures, if applicable. Okay, so making sure that they can take them out, that they can put them in, that they can soak them and rinse them appropriately, and we would be able to score that. The next item is toileting. And so if a patient resident completes a bowel toileting program in bed, so maybe they have bedpans, those sorts of things, we would need, or we would code based on the need for the level of assistance, managing their clothing and doing their peri-cares or their toileting hygiene. Looks like my picture's in the way here, but the next bullet point, if the patient resident has an indwelling urinary catheter, code based on the amount of assistance needed when moving their bowels. So again, if they're not having to urinate, you wouldn't necessarily code that. Again, because of the catheter, it would skew your results to be dependent, right? And so you just would code what they did do. And so again, I think it's important to make note that with toileting, you have to count, okay, can you pull down your Can you pull down your pants? Can you pull down your underpants? Can you actually void? Can you do your hygiene? Can you pull up your underpants? Can you pull up your pants? Can you fasten? Did you unfasten them? Okay, so there's probably eight tasks there that you would calculate and determine, do they need more than half level of assistance, okay, or less than half level of assistance? Okay, so maybe out of those 8 items, okay, maybe they can fasten their pants and unfasten their pants. Maybe they need a little bit of assistance pulling up their underwear. Maybe they need a little bit of assistance pulling up their underpants. Maybe they need a little, or pants. Maybe they need a little bit of assistance making sure that they're clean. Maybe they need a little bit of assistance pulling down their pants, pulling down their underwear, and I can't remember what the other one is, but that is more than half needing physical assistance, more than half of all of those tasks needed for the toilet. And so again, you would be able to score them appropriately if you follow your decision tree. Showering and bathing. So the assessment can take place in the shower or a bathtub or at a sink if they're used to doing full body sponge bath. So if the patient resident bathes him or herself and a helper sets up the material for bathing and showering, then you would code a 5, right? Because they needed setup or cleanup assistance. If they cannot bathe his or her entire body because of a particular medical condition, maybe they just had like open heart surgery or something like that, you would code that based on the assistance needed to complete whatever activity it is. So the items included, and you'll probably want to write these down, the items included include the ability to wash and rinse and dry the face, upper and lower body, okay, perineal area, and feet. Okay, so being able to, those 4 areas, right? Face, upper, lower, perineal, and feet. Actually, there's 5 of them. Okay, and then each of those has 3 things: washing, rinsing, and drying, washing, rinsing, and drying, washing, rinsing, and drying, washing, rinsing, and drying, washing, rinsing, and drying. So that's 15 items that you would be looking at. How much assistance did you provide them? Okay, did you provide more than 7 areas for physical assistance? If so, okay, if you provided more than, or if you provided 8 or more of those different tasks, either washing, rinsing, and drying the face, upper, lower, peri area, and feet, okay, then you would give them more than half assistance, and you would code them appropriately. Okay, so again, it's important to do your activity analysis, come up with the different steps, okay, add those out, assess, did you give them assistance or not for those particular areas, and determine whether or not they needed, or then determine from there how much assistance did you give them. So let's see here, upper body dressing. Okay, so upper body dressing can include a bra, undershirt, t-shirt, a button-down shirt, pullover shirt, maybe a dress, a sweatshirt or sweater, nightgown, pajama top. It's also important to know, excuse me, that the upper body dressing could include a back brace, like a thoracic lumbar sacral orthoses, if they have that, an abdominal binder, a back brace, maybe a stump or sock shrinker, an upper body support device, maybe a neck support, a hand or arm prosthesis, prosthetic, or orthotic as well. And so if somebody is used to having a prosthesis, you would have to make sure that they could put it on and take it off. Okay, so to help calculate this, are they able to dress and undress above the waist? And it includes fasteners. Okay, so can I put on my undershirt? And can I take it off? Okay, that's 2 items. I'm also wearing another shirt underneath. Can I don that one on? Can I put it on? Can I take it off? And can I complete the button? Okay, so that's 5. And now I'm wearing a sweater. Can I put it on and take it off? So for my upper body dressing, that's 7 items that I had to do. Okay, and so then again, I would calculate how many of those did I need help with? Maybe I only needed physical assistance or verbal cue or something like that with 2 of the items. Okay, well that's less than half, and so then I would be coded at that appropriate level. Lower body dressing includes underwear, pants, incontinence briefs, slacks, shorts, capri pants, pajama bottoms, skirts, perhaps a knee brace, if they have to wear some kind of an elastic bandage, stump sock shrinker, or any lower extremity prosthesis. Okay, and so again, it's the ability to put on and take off. And so if the person can put on their underwear, take off their underwear, put on their pants, take off their pants, and can they complete the fastener? Okay, so that's 5 things there. If there's a snap or a button, something like that. Okay, so that's 5 areas that you could consider if that's typically what the patient wears or does. Okay, and so then from there you can say, oh, okay, do they need less than half or more than half physical assistance for you to code that. Last and not least, we have putting on and taking off footwear. So again, this could include socks, shoes, maybe boots, running shoes, maybe ankle-foot orthoses, any elastic bandages or foot orthotics, maybe an orthopedic walking boot, or perhaps if anybody's wearing compression stockings as well. So again, the ability to put on, take off, put on socks, take off socks, put on shoes, take off shoes, tie shoes. Okay, and so again, that could be 5 items there that could be used, and we could calculate that. Coding tips for putting on and taking off footwear. So any patient or resident that may have bilateral lower extremity amputations, maybe with the use of prosthetics or without, the activity of putting on or taking off footwear just may not occur. Okay, and so if there's some reason that the patient maybe doesn't wear a prosthetic or doesn't wear some kind of boot or shoe or something like that, we just simply wouldn't have to code it as not. We could do it as not applicable if they never wore anything like that prior to their admission. If they did perform the activity prior to their current illness, then we would code that maybe not attempted because of a medical condition or safety concern. And so I'm thinking of maybe it's a safety concern for tripping or balance, or maybe it's a safety concern for pressure issues, something along those lines. And so if there's a medical reason for not attempting putting on or taking off footwear, just remember that code does exist. So that is section GG, the self-care section, in a very short amount of time with as very little detail that is, I think, needed or warranted at this time in your OT career. And so, again, know that this is a smaller piece to a bigger a bigger assessment, right? I think Section GG does a really nice job of helping us think of how can we measure a person's level of assistance in a standardized format. And I think Section GG does a really nice job of helping students identify this, if you will. Another key point that I want you to take away is when you are looking at other assessment tools, right? Like some other assessment tools relating to self-care skills, like we just covered the Coleman evaluation of living skills. When we're looking at the reliability and validity of the KELs, right, they compare it with the FIM, the functional independence measure. And so the functional independence measure is very similar to this tool here. It's basically the FIM has morphed into Section GG, and Section GG has more detail to it than the FIM. And so think about how time intensive this assessment or outcome measure is with the use of Section GG, and that if there's studies out there that indicate that the KELs is just as valid of a tool, right? That really should say a lot. And so I really wanted you guys to get an understanding of the complexity of Section GG here, the detail, so that when you're reading other assessments and other studies looking at reliability and validity of certain other assessments, they're most likely going to compare it to the FIM, and which is essentially this tool here. And so I just want you to be able to appreciate that level of reliability and validity of those other tools. So for lab, we're just going to be going through and trying to get an idea of the counting and the coding and those sorts of things. And so I look forward to it. Thank you very much.